We are running late. So, good morning to all of you. I welcome you in oculoplasty IC. That is newer techniques in oculoplasty you don't want to miss. In this course, we are going to discuss newer techniques, recent advances in the management of the thyroid eye disease, retinoblastoma, eyelid malignancies, and new surgery in orbit and ptosis. We are having a team of eminent oculoplastic surgeons of international repute. They will discuss through a short video, short lecture, images of difficult and challenging cases. I hope after completion of this course, attendee will able to manage their difficult cases in easy and efficient manner. I welcome you all. First talk I am going to deliver, that is recent advances in multimodal therapy for eyelid malignancy. I have no financial disclosure. Written informed consent for use of photographs and investigation reports obtained from all patients. Eyelid malignancy may lead to loss of vision and life as well. Often lethal eyelid malignancies are diagnosed late in developing countries in our country. Survival is inversely related to the stage of the tumor at presentation. The eyelid carcinoma are basal cell carcinoma, squamous cell carcinoma, meibomian gland carcinoma, cutaneous melanoma, and rare one is the Merkel cell carcinoma, sweet gland adenocarcinoma, and metastasis to the eyelid. Basal cell carcinoma is the most frequent eyelid malignancy in Western white population. Tumor is of low-grade malignancy, is locally aggressive. Recurrence may occur after excision, but metastasis is extremely rare. Actinic radiation plays important role in pathogenesis of basal cell carcinoma. It primarily involves the lower eyelid and medial canthus. 50 to 80% of BCC are nodular and ulceronodular type. 5-year cure rate reported with margin control surgery is 98%. Squamous cell carcinoma is the second most common eyelid malignancy. Ultraviolet B radiation is the major risk factor. There is a distinct male predominance. Tumor is highly aggressive. There is a tendency of perineural invasion. Metastatic spread occur about in 10% cases and overall mortality 1.6 to 6%. The sebaceous gland carcinoma is a rare, although in Western country, but commonest eyelid malignancy in Asia constitute about 50 to 60% of all eyelid malignancies. This is most aggressive and lethal eyelid malignancy, relatively slow growing and mimics benign lesion resulting into misdiagnosis. Its multicentric origin and intraepithelial spread is one of the reason of recurrence. Sebaceous gland carcinoma predominantly seen in females, and there is a predilection for upper eyelid, lymph node metastasis seen, high recurrence rate, and overall mortality rate is up to 10%. The pathogenesis of eyelid malignancy, the squamous cell carcinoma, chronic UVA exposure involve the proto-oncogene and suppressor genes. The mutation of RAS oncogene seen in 50% cases and CKD-N2A gene 24%, which encodes the P16 tumor suppressor protein. Sebaceous gland carcinoma mutation is seen in P53 gene, and mutation also involves the DNA mismatch repair gene, which encodes the MMR protein that is responsible for elimination of errors during DNA replication. When you see the pathogenesis of the BCC, the sonic hedgehog pathway involved. Here is the patch gene and smoothen gene, and patch gene receptor bind site for the sonic hedgehog ligands. When it binds, it causes activation of smoothen gene, resulting into release of certain cytokines and vasogenic factors which cause cellular proliferation. The accurate diagnosis of eyelid malignancy is very important to decide the correct therapy. One must examine the type of the lesion, whether it is benign or malignant. If there is a loss of eyelashes, loss of normal lid architecture, and if there is a changing pattern of growth, size, then it is maybe malignant. Also look for the site, location, and its extent. And palpate the regional lymph node if there is a involvement. Then the radio imaging, that is CT scan, MRI, even PET, helps to detect the degree of extension, depth, and bony or cartilage involvement. For diagnosis, the histopathological examination, that is type of tumor and its differentiation, is very important. Excisional biopsy, that is diagnostic and therapeutic both. If the tumor is small size, the complete excision with 0.5 to 2 centimeter margin is good. And incisional biopsy, that is diagnostic, if the tumor is too large or deeply infiltrating, and if the lymph node is involved, then one should go for the fine needle aspiration cytology. The immunohistochemistry to look the biomarkers is again very important. That is, vimentin is a biomarker in eyelid sebaceous gland carcinoma associated with the epithelial mesenchymal transition. Vimentin overexpression in sebaceous gland carcinoma considered as novel predictor for lymph node metastasis and poor survival. Similarly, other stem cell markers like LDH1 and CD133, ABCG2, these are associated with poor prognosis in eyelid malignancies. If the lymph node tumor is more than 20 millimeter size, or recurrent tumor are more than 5 millimeter thickness, and in histopathology, if we see the intramural perineural invasion, sentinel lymph node biopsy must be done. Always go for the staging, that is TNM staging, that is a mapping out of the extent of tumor, which also helps in determining the prognosis and survival, and to decide the optimal therapeutic management. According to the TNM staging, tumor may be locally advanced or local tumor or systemic. Then we can choose the treatment modalities. There are various multimodal treatments are available for eyelid cancer, like surgery, chemotherapy, radiotherapy, cryotherapy, laser therapy, and topical therapies. If the tumor is localized, T1, N0, M0, one can go for the surgery. And if locally advanced and surgery is possible, then one can do the adjuvant chemotherapy and excise in toto. If surgery is not possible, then first go the neoadjuvant chemotherapy. And if the lymph node metastasis, then simultaneously in block excision and radical neck dissection can be done. In case of metastatic cancer, only palliative chemotherapy or radiotherapy can be given. Surgery is the gold standard treatment and only curative therapy. Determinant of successful surgical therapy are absence of local infiltration and distant metastasis. Microscopic invasion necessitates the frozen section biopsy, and sampling or resection of lymph node is important if there is a lymph node metastasis. Goals for surgical excision is complete histologically margin control, tumor excision is important, and to restore the anatomical integrity to provide the best cosmesis after excision. Principle is to reconstruct the anterior lamina and posterior lamina together, preferably at least one lamina with intact vascular supply. Other lamina can be free graft. The selection of appropriate technique of reconstruction is very important. It depends on the size of the defect, vertical and horizontal, location of the defect, whether tumor is located medial canthus, lateral canthus, and lid margin is involved or not. Age of the patient, tissue availability, and what patient wants, and it also depends on the expertization of oncologist. If the defect is up to 30%, one can do the direct closure. If defect is 30 to 50%, direct closure with cantholysis and canthotomy can be done. And if it is more than 50%, up to 75, tangent rotational flap and a U-gaze procedure can be done. If defect is larger size, more than 90% or subtotal, then Cutler-Beer procedure can be done. Here is a case of basal cell carcinoma, left upper eyelid in a young female, completely excised and well reconstructed by Cutler-Beer procedure, last 5 years, she is asymptomatic. And another case of recurrent basal cell carcinoma operated thrice in other center was operated by reverse Cutler-Beer technique. Again, sebaceous gland carcinoma of the left upper eyelid, lower eyelid sebaceous gland carcinoma reconstructed by Cutler-Beer technique. This is a case of lower eyelid sebaceous gland carcinoma involving temporal half, that is temporal rotational flap was done. Another case of basal cell carcinoma, right eye involving medial cancer, that is most bad prognosis case, treated by mustardy cheek rotational flap without any recurrence for last 3 years. Then sebaceous gland carcinoma of right lower eyelid, again managed by mustardy cheek rotational flap. Then second option is the chemotherapy. If surgery is contraindicated due to poor general condition of the patient, or patient refuses the surgery, or extensive surgery leading to disfigurement and functional loss, then we can go for the chemotherapy. That is an anti-neoplastic drug which kills the tumor cell by interfering with the cellular function and replication of the cell. The chemotherapy may be 3 types. Primary chemotherapy, that is used as a sole anti-cancer drug. It may be curative or palliative. Adjuvant chemotherapy, that is given after surgery to mop up the microscopic residual. Neoadjuvant chemotherapy, that is given before surgery or radiotherapy. The neoadjuvant chemotherapy, it debulks the tumor to alleviate the surgical damage, to eradicate the micrometastasis after surgery, and leading to improved disease-free survival. The chemotherapeutic agent may be cell cycle specific like antimetabolite 5-FU methotrexate, cell cycle non-specific like alkylating agent like example cisplatinum, and they may be combination action. How to choose the anti-cancer drug, whether single drug regime or combination? Single drug regime, it kills a small fraction of the tumor only, while combination drug kill larger fraction of the tumor. The response rate is low in single drug regime, complete remission is infrequent, and there is a chances of drug resistance with single drug regime. While combination drug regime, the complete remission is possible, but there may be a chances of high toxicity. Before choosing the combination drug, 3 things one must consider. Avoid the drug with similar toxicity, choose the drug with different mechanism of action, and use maximum therapeutic dose of the chemotherapeutic drug. Before starting the chemotherapy, pre-chemotherapeutic evaluation is important to establish the diagnosis and to look the fitness of the patient. The comorbidity of patient, performance status, and physical examination, and body surface area must be evaluated to calculate the dose. And baseline blood investigation like hemoglobin should be more than 10 mg/cent, total blood count should be 4,000 above, platelet at least 1 lakh millimeter cube, and blood urea should be less than 20, serum creatine again less than 1.5. The counseling is very important before starting chemotherapy. Explain about the disease in a simple term to the patient, and extent of tumor, what was the plan and side effect of the treatment, and explain the prognosis. Give accurate answer of the question to the patient, and involve the professional counselor if necessary, because most of the cancer patients are psychologically compromised. Aim of the therapy is clearly whether it is curative or you are going to only palliate the patient. Informed written consent should be taken. Dose of the drug, chemotherapy, it should be standard dose, but can be adjusted according to the patient's performance and nutritional status, and even during chemotherapy, any renal function derangement. Always choose the drug schedule according to cyclic manner, because it give the prevent the drug resistance, give normal cell time to recover the drug side effect, and number of cycle based on the type and stage of the carcinoma at side effect. We are using cisplatin and 5-fluorouracil schedule for the basal cell carcinoma, sebaceous gland carcinoma of the eyelid. Cisplatin, that is 75 mg/m² on day 1, and 5-fluorouracil, that is 750 mg/m² on from day 1 to 5. And these are given every 4 weeks of interval. At least 3 to 4 cycle is sufficient. Then pre-chemotherapeutic drugs are important, that is IV fluid. So patient well hydrated to prevent the tumor lysis. Antiemetic should be given, particularly if you are giving cisplatin, that is a nephrotoxic drug, so diuretics should be given. Always evaluate the response of chemotherapy according to WHO criteria, whether the tumor is complete response, that is disappearance of all tumor up to 4 week, more than 4 week partial response if there is a reduction of more than 50%. And if there is no response, means less than 50% reduction in tumor size or increasing the tumor size. And also evaluate the drug toxicity, and we can take the histopathology pre-chemotherapy and post-chemotherapy. Here is the patient with histopathology were taken after chemotherapy. This is sebaceous gland carcinoma, neoadjuvant chemotherapy and reconstructed, and the large tumor which was given a neoadjuvant chemotherapy followed by radical neck dissection and simultaneously with the lead reconstruction by Cutler-Weir technique. The drug toxicity, the common myelosuppression, GI toxicity, hepatotoxicity, and alopecia. There may be specific toxicity, as I told, that cisplatin can cause nephrotoxicity and ototoxicity. Then comes to the radiation therapy. The external beam radiotherapy by electron radiation or kilovolt photon radiation can be given for the larger tumor. And the side, it is associated again with the side effects. It can cause hyperpigmentation, ectropion, entropion, xerophthalmia, radiation keratopathy, and cataract. The interstitial brachytherapy we are giving for last 3 years, the targeted radiotherapy, that is a minimally invasive radiation technique where we implant the iridium wire, that is through 2 to 3 wires parallel between 7 to 9 millimeter apart, which gives the 50 to 70 gray radiation. And indication is the tumor is less than 3.5 centimeter, absence of node metastasis, and we can give also it post-chemotherapy. Here is another patient having large sebaceous gland carcinoma involving the orbit. After 3-4 cycles of neoadjuvant chemotherapy, external beam radiotherapy was given. And the non-resectable tumor where only palliative chemotherapy followed by external beam radiotherapy was given. This was another extensive case of the squamous cell carcinoma complicated by orbital meiosis. I removed all maggots with mechanical debridement with using turpentine and chloroform, and later on 3 cycles of chemotherapy, and then external beam radiotherapy was given. Patient is planned for the spectacle mount. Alternative therapies are also available like hedgehog sonic pathway inhibitor, immune checkpoint inhibitor, immune response modifier, cryotherapy. The hedgehog sonic, that is vismodegib, and that is a newer drug but very costly drug. And imiquimod, that is again agonist of toll-free receptor, can be given to applied topically. This was a basal cell carcinoma complicated by orbital meiosis. After mechanical remover, I used the imiquimod and then excise this. Another case of extensive BCC. But imiquimod is a local toxic drug. It can cause conjunctivitis, keratitis, lacrimal, and ectropion, diminution of vision. So finally, I conclude that eyelid malignancy is a quite common morbidity, and its management is challenging in our country. Early and accurate diagnosis and appropriate treatment is mandatory. Surgery is the gold standard and only curative treatment. Complete surgical excision with tumor-free margin with appropriate lid reconstruction have been advocated. And neoadjuvant chemotherapy reduces the tumor bulk, allowing less extensive surgery, and hence advised for the advanced stage. Thank you.